members on the call. They can introduce themselves briefly, just a brief couple of, 1 minute about themselves. Is there anyone new? Okay. I don't see any takers. Um, Great. Is it Dr. Daniel? How do you pronounce your last name?
I go by Thiag.
Tiag. Okay.
My whole name is very difficult for people to pronounce, so
Right. So you,
I've
you go by, okay.
I've gone to help people by shortening it.
Great.
That is fantastic. Okay. This is number 14.
16. I think
What?
it's 16.
Oh my goodness. I remember when we started this, and it's always like this, right? It starts slow, now it's building up. We're already at 16. And great, we'll keep going. This is a monthly seminar that we have, invite consortium members to speak. And very briefly, Dr. Lee, you want to do this or I should do it in terms of a brief introduction about the Bioinnovation Center?
Oh, you're on a roll. Keep going.
Oh no, it gives me time to look at the things so I can memorize it. So yes, Dr. Lee will
Well,
tell us.
I have to give a talk at the All African Convention in Boston on Saturday. So I have been practicing this spiel about the Bioinnovation Center at
Perfect.
Academic City to the point where I can't put two words in front of one another and get it straight. Um, in any case, it's a partnership between Academic City University and Northeastern University and the nonprofit 4GBI with the mission to try and foster the development of a biomedical instrumentation and device industry in Ghana. Our evaluation of the status of resources for healthcare delivery in West Africa is such that basically the needs of African clinics are so different from those in Europe and North America that there really are no devices that are optimized for the conditions under which they're being used in West Africa. And so most of the instrumentation that are used in clinics tend to deteriorate rapidly. Uh, Malfunction early and end up having very short half-lives because of the very long supply chains for these instruments. The It's very difficult to get maintenance contracts or to maintain or to repair these instruments, and so really they are a huge waste of resources. And if we could start developing an industry in Ghana to supply uh, instrumentation that is designed for the conditions of clinics within West Africa, there would be huge advantage both in terms of healthcare delivery and uh, economic well-being for the region. And that's sort of the rationale for the development of the Bioinnovation Center is to try to foster the development of companies that can start producing medical devices and instruments in West Africa for West Africa. Is that acceptable, Francis?
Perfect. I couldn't have said it. Well, I couldn't say it. You really nailed it. That's great. Ah, yes, we got the things going on. Excellent. Okay, Doctor, it's my pleasure to introduce Dr. Danu Tiag today. She's an assistant professor of obstetrics and gynecology and affiliates faculty of biomedical engineering at the University of Michigan Football School. As a clinical scientist, she focuses on designing and clinically evaluating medical devices and simulation-based educational programming, specifically for the goal of women's health equity. This is crucial as medical devices and programming not designed for the context of use are typically neither sustained or disseminated. Examples of our work include devices for cervical cancer screening to diagnosing postpartum hemorrhage, as well as simulation-based education to prevent cesarean deliveries, to conducting less invasive gynecological surgery, She also focuses efforts on capacity building for women in engineering and clinical research with efforts in Ghana, Rwanda, and the US. As you can see, she travels quite a bit. As we speak, I believe she's in the US, right? Right. And she has been recognized for her efforts with the University of Michigan Outstanding International Collaboration Award and as Stat Wonder Kid. I don't know what Stat Wonder Kid is, but I know it is fantastic. Well, guys, join me in welcoming Dr. Tiag for her presentation today.
Hi, everyone. Thank you so much for having me, and Dr. Francis for that kind introduction. So just like Dr. Lee was mentioning, all of the reasons why devices sort of being made for high income countries going into low resource settings don't work, that is exactly why my research group does the work that we do. So I'll be talking about global women's health innovation and the concept of designing for equity. I have no disclosures or conflicts of interest. So overall, my research group, Reproductive Engineering for Health Access, focuses in on design and evaluating medical devices and medical education simulation or public health programming for global women's health equity. And the different disciplines that I have personal training in to be able to make this happen, as well as folks in my research group, bring in our biomedical engineering or any type of engineering, obstetrics and gynecology, or any type of clinical women's health related discipline, public health, as well as global health. And then why we do this work. So I think Dr. Lee is going to say it way better than the slide tries to describe it, but most technologies are made for high resource settings. And then those same technologies are attempted to be disseminated in low resource settings. And for all of the reasons that he mentioned, it does not work, right? Folks don't have the appropriate level of training maybe to use that device because it's brand new and no one provided training on them. Maybe it doesn't have the correct voltage to be able to work in that setting. Maybe they don't have the tools or parts to be able to do the repairs or never receive the training to do the repairs. So because of that, a lot of these devices end up sitting in rooms, end up getting put into trash, and have lots of different environmental effects that are negative without having any positive clinical effect. So the goal of my research group is really to design specifically for low resource settings to help bridge this gap. So because of that, my work has a large emphasis on human-centered and equity-centered design, which is really what we're going to be going more into today. So I like to highlight the design thinking framework. And overall design thinking is one of the frameworks that are sort of housed within human-centered design and one of the more commonly used frameworks within medicine. So overall, the various components are empathize, define, ideate, design, test, implement, and then review. And I present this in terms of a linear process and a step-by-step progression for the sake of doing this presentation, how design thinking framework is presented. But in real life, this is not a linear process. There are times where we go to test, we have to go back to ideate, where we go to implement, we have to go back to design. And you'll see some of that naturally in this example that I'll provide of the work that I'm doing. But overall, this is the general concept, but there's a lot of iteration that happens among all of these different steps. There are also a lot of different frameworks to do human-centered and equity-centered design. I provide this example in terms of this is one of the more commonly used ones in medicine. So overall, for a context of the project I'm going to present on, everything that my research group works on were all developed based on needs from either my Ghanaian or my Rwandan partners. I primarily work with Korle Teaching Hospital in Accra, Ghana, which is the largest teaching hospital in Ghana, the third largest in sub-Saharan Africa, and then primarily work with University of Michigan, both biomedical engineering as well as obstetrics and gynecology. Given the time, my goal is to present one medical device that my group is working on. It is a class 1 medical device for urine-based human papilloma virus or HPV screening. And I will go into all of these details in a little bit here. So overall, the progression of this presentation will be in terms of going along with design thinking framework and tying in the example of how we're actively applying this in the work that we do. So with empathize. The goal here is really to understand the problem, understand what the ecosystem is, understand what contextual factors are affecting any of these problems or future implementation. And we do this by doing lots of customer discovery interviews or doing more observations. And the whole goal of this is that the folks that we're talking to who we believe are the interested parties being affected by this problem, either in a positive or negative way, they're telling us what they need. At no point is my team going to them being like, do you feel like you need something for cervical cancer screening? Or do you feel like you need something for postpartum hemorrhage? They're telling us, oh, we see a lot of severe cases of cervical cancer because people haven't been able to get screened, and talk to us more about why screening isn't happening, et cetera. And people are essentially telling me and my research team what they need. So all of this to say, nothing my research group is doing is truly novel in terms of that we're coming up with this brilliant idea. We're really just listening to folks who are in this every single day and understanding where their concerns and their pain points are, and working with them to see where some sort of innovation could potentially help to alleviate even a little bit what that concern is. And at the end of this, this is really where we're developing our need statement or a value proposition hypotheses, depending on if you want to view it from an engineering or a business side. So if you look at this urine-based HPV screening, we did the same thing. My team was in Ghana. We were talking at the Reproductive Health Center. We were observing their morning meeting and seeing that a lot of folks were having concerns with cervical cancer. And we know that cervical cancer is the number one cause of cancer-related female mortality in low and middle income countries. It's the second most common reason in Ghana specifically. We also came to find out that less than 20% of people in low and middle income countries have been screened. So compared to an example in a high income country, for example, in USA, we're around 70%. And if we look at the WHO goal that they're trying to reach by 2030, the goal is 70% of people to be screened. In talking with more healthcare professionals, which always includes clinicians, midwives, nurses, and talking with patients, as well as doing a more thorough literature search, we came to understand that the current methods, primarily cervical sampling, which is done by pap test and co-testing, are expensive. And especially in Ghana and a lot of low resource settings, screening is not covered by a national health insurance scheme, so patients need to pay out of pocket. It's invasive. So for folks who are not familiar, this is a speculum, and this gets placed into someone's vagina to then be able to see the cervix and be able to collect a sample. So as you can imagine, this is a very uncomfortable procedure that happens, and it also requires skilled professionals. If I were to give just anyone a speculum, they probably wouldn't be able to put it into a vagina properly, wouldn't be able to find the cervix, wouldn't know how to collect a pap test appropriately to make sure that we're collecting in the right area, we're getting enough cells, etc. So it is someone that needs to have sufficient training to be able to do all of this. Because of all of these things, in Ghana, less than 5% of people have been screened because of these barriers. So our value proposition or need statement was that urine-based HPV screening will increase screening rates by addressing current barriers. And that's sort of where we start in terms of how can we address these barriers specifically based off things we've heard in the community to really then see, can we try to increase cervical cancer screening? So as we go into this next stage here with design thinking, now we need to define it out more, right? We know what the overall need that we're trying to solve is, but that doesn't mean we have all of the nuances of how to make it there, right? There's a lot of different ways that we can approach this need statement. So this is where we really figure out, what is your project plan? So technically, what does the solution need to be able to do? From a business wise, thinking about future commercialization, what do we need to consider? And then who are the team expertise or resources? In my case, where do I need to get my grants from to be able to support doing this type of project? So then we come up with our device requirements. This is one aspect of what happens in this design stage. And again, like we identify the need statement, almost all of these device requirements come again from talking to the community, right? So we understand in terms of what sterilization methods exist at Corley-Boo and other facilities, what type of materials and manufacturing methods are available in low resource settings. Some of this is based off literature in terms of what do we already understand about urine-based HPV screening to be successful in this, right? We know that it needs to collect the first 20 cc's of urine. So this is why standard urine collection would not work. If I were to give any of you a urine cup and say, please give me 20 cc's, most of us would be unsuccessful in that. We would either collect too little, which then means there might not be enough cells with HPV for us to test, or we might collect too much urine, which would then dilute down those cells in HPV, which is why we need a device here to be able to help us with collecting those 20 cc's. The other aspect of why we need this device is we can only collect that first catch, meaning that first 20 cc's when you start your urine stream is all we need, because we know that that has the highest concentration of HPV that has sort of been shed from the external genitalia area to be able to collect it. So again, right, maybe folks, if I gave them a urine cup, could collect 20 cc's, but maybe they collected a little bit, they urinated some more, and then they go back being like, oh, I didn't get the full 20 cc's. Now we're not getting that first catch urine. And then some of these other requirements are more focused in on biocompatibility, what needs to be for medical standards in terms of it being safe for human contact, etc. But again, when we just determine our entire list of requirements or just entire list of minimal optimal specifications, being able to rank the priority of these requirements, it's all based of talking with folks in the community that are interested parties in this need statement to really understand more what do we need to address and how significant are these things that we need to address. So now we go on to ideate. So here we're really thinking about, we have our device requirements, we have our specifications that we're hoping to meet. What are the possible solutions? How do we evaluate the strengths and weaknesses of it meeting one requirement, not meeting another requirement? Does it meet a bunch of low valued requirements, but none of the high valued requirements, and really trying to do different decision matrices to be able to figure this out. And then trying to prototype different options to see what may work. So in this stage for developing a urine-based HPV screening device that meets our device requirements, we did different types of ideation in terms of, here's a general concept of, we wanted some sort of funnel, we wanted some sort of one-way check valve that allows for collection, we wanted somewhere that the urine gets collected. And this picture is here just as an example to sort of show the back and forth, right? We're technically still in the ideate stage, but we've already done some testing. And the reason for that is we're not truly going to know if our device can meet all of the requirements and specifications unless we're doing some of that testing and then coming back and doing more ideating and prototyping. So there's a lot of going back and forth that we do here that's very iterative to see how can we best meet all of those requirements. So now we're designing it. So this is really to try to figure out what is your minimally viable product. So I love this picture. This is not my picture. This is definitely taken from Google. But the goal is, if I am trying to get to the truck that's going to help me achieve all of my goals and dreams, I'm not going to be able to start with just wheels. That's not going to be able to help me achieve anything, right? Wheels on its own don't do anything. But I need to start with something where maybe I can start carrying something like a bicycle. It's not very efficient. It takes a lot of energy. Maybe you can't carry a lot, but at least it can go from place A to B. I can carry something very similar to where I want to end up. And that is the goal of this stage in terms of really trying to figure out, how can I at least show that I have a proof of concept that my large future commercialization idea is going to work, but that I need to start somewhere to really prove, and especially in the research world of trying to continue getting grant funding, of showing I have some data to prove that this works. If I have some more money, resources, I can really take it to the next level and be able to address that final need statement. So related to that, this is where we ended up on our final like proof of concept prototype. So overall, you can see that there is a funnel here. There is a bracket. This bracket allows it to sit, for this one, on a Western toilet, or in Ghana, a water closet. It has a one-way check valve, and then it has a collection vial. So this collection vial is specifically designed where it only collects 20 cc's of urine. Once that 20 cc's of urine is collected, this check valve will close off, and then the rest of the urine will go into this funnel. And then in this funnel, the urine will be able to come out into the toilet. And then we can always dump out the rest of the amount of the funnel and then collect what's in the vial for our actual sample. And this design, again, only works on a Western toilet or water closet, right? That is not going to be the most common method that's used in a lot of low resource settings as a toilet type. But again, the goal was a minimally viable product, right? We wanted to show that this concept of being able to collect the first void 20 cc's can work. And that's what this design did. So now we go on to test. And this is really where you do your combination of verification testing, you do your validation testing, and also your regulatory clearances. So because my devices overall all get manufactured in Ghana, I primarily deal with the Ghana Food and Drug Authority, also called the FDA, but Ghana FDA. But the concept is the same overall in terms of really looking at the different regulatory clearances to be able to make sure as I'm going into clinical testing, is my device meeting all the requirements to be able to safely do that per the standards we've set? So the first part in terms of some of this device requirements is doing the verification testing in terms of understanding, are we able to actually collect that first 20 cc's of urine? Are we able to collect that first catch of urine? Looking at biocompatibility of the materials that we selected, trying stability against Western toilets, doing simulated testing to understand how much weight the device can handle, understanding what materials and manufacturing methods are in Ghana and other low middle income countries to really understand what do we need to change. Does sterilization of the material make sense? And overall doing a cost analysis as well. The other part then is doing clinical testing to understand, right? All of this is only as good as in terms of being able to address the clinical effectiveness of this. So for this, we did a clinical trial of 100 patients at Corlebu Teaching Hospital in the Reproductive Health Center, where we recruited 100 patients who were known HPV positive. And this was all done after we got ethical clearances from Corlebu. We got Ghana FDA approval in terms of doing it. We were able to manufacture this device in the country. So overall, the way that it worked is that patients were recruited based off an HPV database at Corlebu Teaching Hospital. They were done with a phone screening in terms of did they meet our inclusion exclusion criteria, were they interested? If they were interested in participating in our trial, they came into the office, and then we were able to do their full consent. And then we asked them questions in general about their demographics, their urination practices, any past medical history that could potentially affect any of these results. The device was set up by our research team on a Western toilet or water closet, and then the patients provided us with a urine sample using our device. The device, after that, the patients or participants completed a survey talking about if they liked the device, what they didn't like the device, based off different validated questionnaires here. And then after that, they had a healthcare professional collect a cervical sample, so a PEP test that we were able to do HPV screening on. And again, they completed another survey with the same exact questions, asking them how they felt about PEP test, etc. From there, we were able to get all of those samples sent off to be tested for HPV DNA. So looking in terms of with the cervical sample, looking related to the urine sample, in terms of was HPV DNA detected, right? That's really what we care about in clinical practice is if I start using this urine test, no matter how much patients want to use it or how much they desire to use it, if it's not going to help me do cervical cancer screening, we can't do it further. We also can't use it. We were successfully able to find that we had 93% HPV DNA detection related to sensitivity specifically. So making sure if the cervical sample had it, that our urine sample also had that HPV DNA among 100 paired urine and cervical samples. And for context of what that looks like in the bigger scope of a clinical practice for cervical cancer screening, If you look at pap test with co-testing, we say that that probably has about 98, 99 sensitivity, which is why it's our gold standard. The other form of cervical cancer screening that's approved and is used mostly globally is self-swabbing. And that one, if you look at the sensitivity of it, ranges in about the high 80s, so about 85 to 87%. So based off, again, our preliminary results, but we're only looking at sensitivity and we're only looking at HPV DNA, we're already showing that this has potential in terms of maybe being superior to something that's already on the market, even if it's not as good as the gold standard, but maybe could overcome some of those barriers. We also asked clinicians. We talked to 36 different clinicians at Corley Teaching Hospital to understand how they felt about the urine-based HPV screening device. And 30 out of 36, about 84%, said that they agree or strongly agree that this device meets their approval. When we did more qualitative analysis to understand this, we found out that the main concern people had was one in terms of accuracy. We did not have this clinical trial done when we had talked to clinicians. So this was just asking them based off this concept, not specific sensitivity or specificity values, but they were concerned about the accuracy of it, rightfully so. They were also concerned about in terms of this device being used in a clinical setting because they sometimes didn't feel that the washrooms there were as clean, et cetera. Of the same 100 patients who had both the urine and cervical samples done, 93% of them preferred our device with urine-based HPV screening versus getting a pap test done. Again, looking into that on a more qualitative basis, the reasons that they preferred that were for a lot of the reasons that came up as barriers. So overall, a pap test can cost about like 40 to 50 400 to 500 Ghana CDs. And our test would probably be about half the cost of that. And the reason for that is our device is reusable. There's one single use portion there, but the rest of it is reusable. So the main thing folks are paying for is the lab analysis, not the materials, device, et cetera, which is different than pap tests where they need to pay for all of the materials, the visit, et cetera, as well as the lab test. So we're able to reduce the cost by about 50%. They also thought that this was non-invasive, right? Folks already know how to use a toilet and urinate, and they're not doing anything different with their device other than using a toilet and urinating. And they also appreciated in terms of that they could potentially really do this anywhere and that they could do this in their own privacy rather than needing a healthcare professional to take any of these samples. And that was a lot of the reasons why patients preferred our device. Reasons why people were hesitant about the device was mainly around the accuracy of it. A lot of patients had, or about 7 patients had concerns in terms of if we're worried about cervical cancer, it makes sense for us to swab the cervix. How is a urine test going to help? So again, we did not have any of this clinical trial data because these were the participants that we were asking when we did it, but really trying to, that was their main concern in terms of, is this going to provide me the quality of care that I need? So now we go on here in terms of implement. Obviously, based off some of the things that I said here, we are not ready in terms of this device for implementing. So we're actually starting back from the beginning of repeating some of the design process. And the reason for that is one, in terms of can we improve that accuracy even more? Based off our previous design, we were probably not getting exactly that first 20 cc's of urine because of it being a closed system. So we're trying to evaluate, can we revise some of the design concepts behind it? Patients also really wanted to use this at home, and clinicians also thought it'd be more important to use this at home and outside of a care facility. So we're trying to revise the design in terms of, can it be used for the pot? Can it be used for squat toilets? Can we make it more user friendly so patients who may have minimal education around this, who may have minimal interaction with the healthcare system, could still potentially put this together and be able to use this in their home? Or at CHIPS facility, which is like community health sites in Ghana. And then also looking at point of care testing in terms of, especially if folks are being able to do this in more remote areas, can we include point of care testing? So then that way, folks can get the result and know when or how they need to follow up rather than waiting for these results back, where we're probably losing a lot of patients to loss of follow up based off some other studies done in Ghana. And then overall, after we were to implement this, just to sort of complete this design thinking framework, is then review. And this is really where you want to perfect that idea, right? So maybe you're going from minimally viable product all the way into like your most perfect design that you can imagine that's saving the entire world, which is why we're all trying to be here in terms of trying to make our small little impact of how can we improve health equity. But in terms of understanding what are the successes, what are the obstacles, where can we sort of improve things? And then more from a business aspect of like, what is the brand that we're trying to promote here of trying to commercialize this? And how can we continue making a future company or the device itself continue to exist in the world? So overall, that's sort of how my research group goes through the design process. And here's one example of the device of how we've done it. All of the devices, all of the projects that I work on are done the same way in terms of really understanding on the ground what the community needs, wants, how we can address the resources and contextual factors around there. Just to highlight some of the other projects my research group is working on, there's one here. This is a mechanical rate controlled IV infusion pump. So in obstetrics, for example, we give magnesium when we're concerned about preeclampsia and seizures. In the operating room, we give anesthetics to make sure people aren't feeling pain during surgery. We need to make sure we give all of those medications at a very specific rate. And a lot of those devices are currently very expensive. They currently use electricity. And some of the intermediates that maybe aren't very expensive, don't use electricity, are not very accurate. So our device here is purely mechanical, but can still provide that same level of accuracy. This is a device here in terms of quantifying blood loss from the uterine cavity. So this can be used for diagnosis of postpartum hemorrhage, which is the number one cause of maternal mortality, or for heavy menstrual bleeding, which is the number one cause of anemia in a lot of low resource settings. And a lot of that is because we as clinicians are terrible at looking at someone's blood loss and estimating essentially how much they lost and what clinical impact they have. So really trying to figure out, is there a way that we can manufacture something in country to be able to make this happen? Because a lot of devices that address this exist, but unfortunately they can't be manufactured in Ghana and a lot of other countries, which actually limits its ability to be used clinically. And then these models on the bottom are all for medical educational programming. So this one is for a procedure called external cephalic version, where essentially we can do a procedure as clinicians to be able to flip a baby into a head down position to promote vaginal delivery. And then these ones are to teach surgery related to minimally invasive gyne surgery, which is essentially where we can use a camera to put into someone's belly or put it into someone's uterus to then be able to operate so that people have small incisions instead of large incisions. And then this is a procedure for pudendal nerve block, which is a type of pain modality that could potentially promote an introduction of new gyne and OB procedures. Thank you so much.
Thank you very much, Danny. Round of applause for that excellent presentation with the emojis. If we're in the call, very insightful, very extensive, and more importantly, touching on an issue that continues to get a lot of traction in recent times, which is women's health. So thank you very much for the amazing work you're doing. So this is the point where we take questions. You may type out in the chat or feel free to put your hand up and we will call you up with your question. Floor is open. Whilst everyone's contemplating what questions they may have, then we'll have a few. Okay, Santosh, please go ahead.
Yeah, the HPV screening by this urine catching device, the results look pretty promising. Could you maybe elaborate on maybe what the next concrete milestones or next steps for this is?
Yeah, so different things that my research group is currently working on. One is in terms of we are redesigning the device to see how we can have patients use this at home. So right now it is set up by a healthcare professional in a health center. So instead, can we make the device more user friendly so that they can still accurately collect samples at home is one avenue that we are focusing on. And again, then do more preliminary testing to make sure, do we still have the same effectiveness? Another avenue that my team is working on from that is doing point of care testing. So, can we develop new technologies other than PCR that are being used for other point of care testing into the realm of HPV screening so that people can take their urine sample that they've collected on their own and then be able to use a point of care platform to get their result right away of do they need further follow up or not related to HPV? And then the other aspect is taking the device that we already have promising results on and doing a larger clinical trial. So, in the clinical world, the actual standard that we're looking for cervical cancer screening is something called CIN2, which is essentially the middle ground stage of precancer. And being able to go from that aspect then of understanding when we're doing gold standard testing versus testing with our device, are we able to actually detect precancer?
That's great. Thank you.
Okay, thanks for that question, Santosh, and for your answer, Danny. Abe, your hand is up. Please go ahead.
Yeah, my question has to do with the first in the design thinking has what is, had emphasis. And I'm thinking with respect to biodesign process, what's key about that emphasis? Because if you're trying to, need identification, is this, why is that word emphasis is used as beginning of the process? Yeah.
Just to make sure I have your question correct, are you asking in terms of why I emphasize like human-centered design as well as design thinking frameworks?
Yeah, I mean, I'm thinking about, identifying, which will include, immersion and, in the disease area and in really observing the procedure. So I guess I'm asking myself, emphasize what?
I don't know if I fully comprehend the question, but I can try to take a stab at it and then please let me know if I'm headed in the wrong direction. So I think the principle that my research and group focus on is that we have the skill set as engineers, we have the skill set as researchers, we have the skill set as clinicians, but we are not the folks that are practicing in Ghana and Rwanda and other countries that I work in. So it is impossible for us to know what the needs are. And that's why we have this emphasis on human centered and equity centered design principles to really make sure that we are addressing the local needs. Right? I can come in as an outsider who practices at University of Michigan, go to Corley Boo and be like, oh, wow, we don't do that in Michigan, but that doesn't mean it doesn't work at Corley Boo, right? There are completely different normal okay ways for us to all do different types of clinical practice and I am not able in terms of really identifying what are these different things because I don't practice there, right? I do some surgery, but I am not a Ghanaian. I am not a clinician officially there. So that's why we have that emphasis is really in terms of bringing in the community to be able to do all of this work together. I think the other aspect of it is really understanding what are the contextual factors that affect any of these devices being implemented, right? We know, especially in global health technologies, it can take over, I think it's about 27 years, is what the most recent literature says, sort of to go from idea to commercialization. And the reason for that is we don't involve some of these downstream dissemination, implementation, commercialization outcomes earlier, and we sort of take it a step at a time. But by doing this, we're already understanding a lot of that information earlier on, right? There's still going to be things that we've missed. Obviously, this has not been commercialized because we're still testing it. But I think the goal is by sort of us involving the community earlier and really understanding who are those interested parties that are going to be affecting this. For example, in our most recent testing, we were able to talk with the Ghana Health Service. We were able to talk with the Ministry of Health and sort of understand these different factors that could affect future implementation. Then we can hopefully have more success in terms of implementing any changes into the earlier clinical testing into the design phase, which can hopefully promote it down the line. And again, I apologize if that wasn't the exact
No,
question.
I guess no, it makes sense. I just was thinking that when you use the word emphasis, I mean emphasis on what? That what I'm getting the sense is that you dig deeper into the needs, into understanding how in that specific environment, before you even going to invent or innovate, what is the need? How
Mhm.
is this? How will this get to the market? So you are taking a step back to kind of have a open-mindedness to just kind of think through what should be focused on, and not only that, but also to is what are the potential stakeholders? Who are the potential, regulatory, clearance, so that you get all that upfront, as opposed to try to design, test, and when it comes to implementing, you're now finding out some, challenges, and that challenges could entirely derail the innovation. Yeah.
Correct. Yeah. Oh, sorry. So now I understand. In terms of when I put earlier that I emphasize human-centered and equity-centered design. Yeah. So specifically what I mean by that is, right, if we look at the traditional medical device engineering process, it's a lot of that an engineer is doing some sort of literature background, maybe has done some observations, but they're not getting that much input in terms of who those end users or people that may be affected by it, but they're going through and addressing all the technical aspects of it, right? And in terms of bringing in that human-centered design and equity-centered design, it's really making sure that the community and the interested parties are involved at every step of the way. So for a lot of these things, we do co-design sessions with the community. So patients, healthcare professionals to understand what do they want to see? How can we revise something in terms of right they don't have the engineering expertise, but by giving us ideas, then we can bring in that engineering expertise to then be able to design these technologies and innovations with them.
That's good. Thanks.
Yeah, great. I'm going to come to you next, Francis, but I just wanted to add on the back of that. So the Medical Innovation Expo that we run annually this year is the 22nd to the 24th of September. And particularly in the first day, it's exactly why we have the clinical immersion session. So that we actually go out to the hospitals in the wards, various stages, and just interact firsthand with the end users and the medics, clinicians, etc. So we'll share that in the chat shortly. If you haven't registered yet, make sure you do. Francis, please go ahead with your question.
Thank you. Thank you for the great presentation. I have two questions, one about manufacturing, the second about clearances. You mentioned your device is manufactured in Ghana. Is this large-scale manufacturing or simply just a couple of things to test?
Yeah, so right now, we primarily do a lot of rapid manufacturing. So in terms of primarily 3D printing, trying to being able to get the access there, because at this point, we're still not focused in terms of large scale manufacturing for commercialization. It's really to be able to do any type of like co-design sessions, usability testing, or clinical trials. So again, we're only manufacturing a few devices at a time. But the goal is, as we're considering our design and our materials, et cetera, even though right now we're still doing small scale manufacturing, we have those considerations in the back end of when we can hopefully do large scale manufacturing, will the same design, will these same materials still apply, but maybe we're going to do like injection molding instead, et cetera.
My second question is about clearances. I would like to know your contact, because how long did it take you to get clearances from the FDA, Kolebu Ministry, and everything else?
Yeah, so I don't need approval from the Ministry of Health at this point because we're doing it for research purposes and it's not being used clinically. So my approval process in terms of Corley Boo, institutional review board or University of Ghana institutional review board can take several months. That is, unfortunately, I've been doing research there for a few years, so now they're familiar with my face and know me.
I see.
But I think it still takes a long time based off that. In terms of the Ghana FDA, I think it has taken an upward of like 6 to 12 months, depending on it, in terms of being able to get approval. But all of it is things that take a very long time. So, for example, even as we're still finalizing some things, we will already submit for Ghana FDA approval in terms of at least trying to get that process started.
All right. And then one more question follow up about data. So you have access to data, and how was that sort of access thing? Because I know data can be quite, access to data in Ghana can be challenging. So was that a smooth process? How did that go?
Yeah, so all of our research infrastructure, et cetera, is in Ghana. So Ghana is or like University of Ghana, Corley is the primary institution that's sort of seeing all of this research. So we do have like data sharing agreements between University of Michigan and University of Ghana that allow us to do some of these things. So for example, we'll use like RedCap at University of Michigan, even though, for example, like Corley Teaching Hospital is the one overseeing the research study, just based off in terms of us being explicit about where resources exist, as well as this partnership that exists as well. But fortunately for this research, University of Ghana and University of Michigan have been doing some sort of partnership for over 40 years. So we have a long-standing infrastructure in terms of doing some of this work. I'm the first one that's sort of doing stuff on the innovation side. So a lot of building those relationships, et cetera, have been new. But it definitely is very fruitful and helpful in terms of that the University of Michigan name is not new in Ghana.
Okay. Francis, does that address your questions?
Yes, thank you very much.
Okay, great. Mark had a question in the chat, and then I'll come to you, Jacob. I think he partly answered, but it says, can you tell us who in Ghana actually manufactures your devices?
Yeah, so in terms of that, it's different 3D printing companies that we've been able to find. A lot of it in terms of who specifically depends on like which filament we're looking for, who's willing to work with us. So for example, like this device was made from polypropylene, which is actually very, very difficult to 3D print. It requires like different adhesion beds, different adhesion glues, a specific type of printer. So we actually worked with a 3D printing company that was willing to work with us in terms of doing additional trainings, trying out different materials, et cetera. But essentially, we will reach out to different folks that do 3D printing in Ghana to understand, based off our needs, what they're able to do and what they're willing to do, and then reach out that way. And I know we're going to try something at Academic City in terms of some of our future printing too, to see if we can try to strengthen this collaboration as well.
Definitely. Great. Jacob, please go ahead.
All right. Thank you. I just wanted to add to the innovation you're presenting within this West African landscape where pap smears HPVs are actually a problem. I think part of the problem, in addition to getting the samples, would be preparing the samples for screening, for diagnosis, right? And that is one of the pain points in our part of the world, where if you're going to have, let's say, 100 slides to be scanned by pathologists, then that becomes a problem. I know in developed countries or in very enhanced labs, you're going to have this digital pathology scanner, which has some AI features to help do screening, plus having a very good pathologist to do that remotely. But yet again, in low resource setting, you don't have that. So even when you collect the samples the right way, processing the samples and doing proper diagnosis and review is another challenge. So just adding that.
Yeah, that is a great point. I think so if you look at how cervical cancer screening has changed throughout the years, Historically, that is how we did all of our screening in terms of that we looked at cells that were collected from the cervix and we had to do slides. A pathologist had to manually look at it, et cetera. I would say maybe my time frame is all disoriented, but several years ago, like not super back far in history, we came to find out that human papilloma virus causes about 95% of cervical cancers. And that really changed our landscape of how we can do cervical cancer screening. So, right, so in a lot of high resource settings, so for example, gold standard here in America still is in terms of we do co-testing. So we look at both those cells under a microscope, AI assisted or not AI assisted. I don't know the logistics behind that in pathology world. But we also look at in terms of HPV genotyping, in terms of looking at specific strains that are high risk and other high risk, essentially. If you look at the new they're again not new anymore, but the guidelines based off what WHO recommends for cervical cancer screening, they actually recommend just doing human papillomavirus screening. So WHO does not necessarily recommend that we need to visualize the cervix. They do not recommend that we need to take cells from the cervix to then be able to look at it under a scope, etc. They really just say if we can do the molecular testing behind to identify genotyping for HPV DNA, then we're probably in a really good spot in terms of being able to screen folks. So if you look at the WHO 70-30-70 goal for cervical cancer by 2030, that 70% is actually just focused in on HPV screening. It has nothing to do with VIA. It has nothing to do in terms of looking at cytology with cells, et cetera. And I think that is a really big change that actually favors in terms of removing some of those disparities that you were mentioning in a lot of low resource settings where that same infrastructure does not exist. Because, right, in terms of if you can run PCR, which, right, you can run multiple vials at the same time and be able to do it, there is obviously the limitation of having the equipment for it, et cetera. But I do think that's probably a step in the right direction of trying to eliminate that. And also recognizing, right, in terms of the resources and technology is why my research group is also working on point of care as another potential avenue to reduce those barriers too.
Great. Jacob's got, okay, thumbs up, we're good. Lee, please go ahead.
Hi, Danu. That's fabulous presentation. You're doing some really great work. I'm really curious about your research team. This requires a team to make this work, and I'm curious as to the distribution of expertise. Do you have engineers, physicians? What makes up this fabulous team of yours?
Yeah, there are a lot of different disciplines were represented across a lot of different countries. So in Michigan specifically, I have folks who are clinicians, OBGYN related or other related, depending on the device. I also work with both mechanical and biomedical engineering here at University of Michigan and mechanical, biomedical, and chemical engineering. I don't know if I mentioned all three, but all three of those disciplines within our School of Engineering. And then also work with contacts in our School of Public Health. We have some folks in policy, some folks in like more international studies. There is a wide variety of different schools and disciplines that are represented in my research group and in the projects that we do. And again, right, some of that varies depending on project to project. But for all of these projects, there is an equivalent group that's not at University of Michigan, so primarily based in Ghana or Rwanda. And that team can also consist in terms of they all definitely consist of other clinicians, other researchers, potentially public health folks, primarily at University of Ghana, primarily do work, like I was saying, at Corley, do a little bit of work at Comfe Noche. And then in Rwanda, the same thing. I do have some engineers that I work with from University of Ghana, but that is very dependent on the project. Primarily, a lot of the engineering stuff does happen at University of Michigan. But if anyone is interested, especially from Ghana in terms of being more involved, would love to talk and figure out ways to collaborate more. And I think that was part of the goal of talking with MC more in terms of how from the engineering aspect, can we collaborate more there?
Fantastic. Yeah, my I'm very impressed. Do you have full-time people in Ghana, or are you just collaborating with people?
So I do have a full-time research team in Ghana, in terms of research coordinator, research assistants,
Mhm.
as we always have projects going on that are requiring data collection, anywhere from a needs assessment to a clinical trial. And then obviously in terms of the faculty that I work with, it really depends on how much effort we can get from grants. But again, not to go into like the bureaucracy of effort in Ghana, but it doesn't always exist.
Yes, yes. No, we don't want to go there. Is the people full-time in Ghana, are they located at the University of Ghana, or Corley Bu, or what? How does that
Um,
work?
they're they're located at Corlebu, because all of the clinical data, collection, et cetera, that we do is there. But then they're able to, like, for example, one of our next studies, we are going to patients' house for this study, actually, where we've revised the design and we're doing at-home testing. So they'll like travel across the country to get different varied viewpoints, in patients' houses using it.
Totally spectacular. Thank you so much.
One last question. I mean, you mentioned about grants. For us, we need to know what kind of grants that you're able to, or agencies that give that grants that we can also tap into. And that is one. And second is in terms of the, you can get grants and pay for people in the US, but how do you do, also pay for folks in Ghana?
Yeah. So a variety of different grants that I get. So I do get internal grants at the University of Michigan. I'm fortunate to be here and have a lot of internal resources. I've also gotten grants from different foundations, in America that are either focused in on innovation, focused in on women's health, depending on what the project is, and have also gotten grants from both the NIH and NSF focused on this work.
Thank you.
Yeah, pretty impressive stuff. Also to get to the place where industry are offering to know where we're getting the money from so they can get a piece of the pie. Great. Patty, please
Yeah,
go ahead. Yes.
if anyone knows any industry that's interested, I would love to be connected.
Yes. Patty, your hands up.
Yes, thank you so much. Danu, congrats again on the good work that you're doing. Let me confess that I have had a lot of interaction with Danu and we've talked a couple of times. She's interviewed me, I have looked at the devices. And one thing I'd like to know is how far have you come with regards to approvals? Where are you now? And depending on where you are now, how can some of us, especially us in the NGO world, who are able to go out and test some of these devices and also help with the advocacy to get them to be accepted, how can we help?
Yeah. Hi, Patty. It's nice to, see you again.
Same here.
So overall, in terms of related specifically to this device for urine-based HPV screening at home, we have already gotten institutional IRB approval from both, University of Ghana as well as University of Michigan. We have submitted initial communication paperwork to the Ghana FDA in terms of discussing next steps, et cetera. So that's sort of where we're at the stage for that in terms of the clinical testing aspect of it. Right now, the phase that we're in is really trying to optimize when we're ready for that clinical trial of usability testing. So we're going in terms of to folks' house to really, understand, can they put it together, where will they store the samples, et cetera, and trying to go from there. But I think in terms of a lot of support, obviously, if anyone has any connections within the Ghana FDA to try to help expedite anything, that would be lovely. In terms of trying to have those conversations. There's only so much, like my partners in Ghana have worked with the Ghana FDA before. We've worked with the Ghana FDA before with this project, but again, just based off how, systems and procedures exist, all of those things do take time. And then I think the bigger thing is really trying to figure out where we can we go with this in the future, right? So from a clinical research standpoint, I can continue working towards funding. I can continue working towards clinical trials to get the, effectiveness data, but right, that's not going to take this into the real world. And trying to figure out who are those people I need to talk about to figure out how can we get this out into clinical practice. Also understanding where is the right way to try to introduce this, try to disseminate this. And I think that's the part where I don't have that business side of mind in my life. And I'm looking for active industry or commercialization partners to be able to do this. So any context that sort of exists. Patty, I know we've talked about this within the NGO world, but either within NGOs or industry of how we can disseminate this in the world and the future, hopefully.
Absolutely. So one thing that I'd like to bring on board with this consortium is for us to be able to identify some of our um, um, manufacturing agencies, no matter how small they are, and see how we can work with them, introduce some of these devices to them so that they take interest. Just as an example, some years back when I was working on maternal mortality, and I still am working on maternal mortality, we needed models, pelvic models that we needed to teach how to detect postpartum hemorrhage and how to correct cervical tears and stuff like that. So I went to Latex Foam, of all companies, Latex Foam, and asked them that they help us to develop a model that is made of their kind of foam, what Americans call the futon. And that was a very unusual partnership, but we showed them how we wanted the pelvic models to be designed. And somebody in there was very interested. So I'm saying this so that we can think outside the box and find out. Some of these devices may be made of plastic. So we might want to talk to some of those that make these plastic containers and stuff like that around the Danu, you know Accra a bit. So when you look at the North Industrial area, we have quite a number of them. So we might want to visit some of them and have a bit of interaction with them, or even invite some of them to this consortium, especially when we have the expo, so that they know what's up. And then they would also want to see how they can pitch in. But one secret I'll tell you, Danu, is we'll talk after. We can talk offline. But one secret I can tell you is if you really want things to go forward in Ghana, do something in Kumasi. If it works in Kumasi, it will work any place. Thank you.
I think we've all taken a bit of that secret insight, Paddy. So thanks for sharing. But very useful points you've made actually, which we've made notes of, and we will try and see how we can move that forward. But I don't see any more hands up, and we're 10 minutes past the usual time, which is a great indication of how engaging, insightful, and the